Welcome to Around the Room, brought to you by the Canadian Rheumatology Association. This episode has been made possible in part by Boehringer Ingelheim. Thank you, Boehringer Ingelheim, for your generous support in sponsoring this episode. The scientific integrity and objectivity of all podcast content is overseen by an independent CRA committee to ensure the highest standards.
I've made more mistakes, to be honest, and there are times when I really have thought I had something only for it not to be validated. So there's no greater joy in finding something in the lab for which someone else can validate. It's tricky work, and you certainly don't want to mislead anyone. So what I've actually built is humility.
That's Dr. Proton Rahman. He is the clinical chief of rheumatology at Newfoundland and Labrador Health Services and holds the position of John Lewis Distinguished Professor at Memorial University. He is a world expert in spondyloarthritis with a particular focus on psoriatic arthritis. His research focuses on genetics of psoriatic arthritis, and he is involved in translational studies and clinical trials in spondyloarthritis. His accomplishments are too numerous to describe here. However, there is one recent honor of particular note. He's a newly appointed member of the Order of Canada in recognition of an extraordinary career that has included building groundbreaking genetic research programs leading to advances in how we understand arthritis. His work in identifying the genetic diversity of diseases like psoriatic arthritis has helped transform patient care, bridging cutting-edge science with real-world impact, all rooted in his own early experiences as a patient. We're really thrilled to have him with us in person at the CRA's 2026 Annual Scientific Meeting in Halifax. Welcome, I'm Daniel Ennis, and a warm welcome to my fabulous co-host, Dr. Janet Pope. Janet, how you doing?
Really well, and really great to be here.
It's really nice to see you. Over to our guest, Dr. Rahman. Welcome to Around the Room, and thank you so much for being here.
Daniel, Janet, I'm thrilled to be here, and I'm looking forward towards the conversation.
So some great stories are best told in reverse. So I'd like to start maybe at the end with your appointment to the Order of Canada. You shared an anecdote with the CBC that I found striking. You said that you received an email titled "Sharing Good News" sent from the Governor General's office. And I have to say that if I ever got an email like that, I'd assume it was spam and I'd probably put it in the trash. But I'd like to know if you can tell us about that moment and what this award means to you.
Do you know what? I was really humbled to receive the award, but when I first got the email, I didn't think too much of it. So we had nominated a colleague for the Order of Canada. So I just didn't quite understand the process. So I thought this was the Governor General's office just contacting me regarding the decision for our colleague. So I thought it was about them. I was just in the middle of something. I just didn't have the time to get at it, and I forgot about it. And so it was till maybe 15 or 20 minutes later, I realized I should look at the email. And just to my surprise, it wasn't actually about the colleague. It was regarding me, but I didn't really find that out. So when they call you, they just ask, can they call you about sharing good news? So I just texted my number and I said, yes, just call me whenever you get a chance. And it's at that time I just came to the realization they were talking about me. So it was just, I was totally surprised.
It's an incredible honor and so well-deserved, having looked through your history and your research output. But beyond that, I think you're described as legendary by a colleague just because of your status within the rheumatology community in Canada. What was the actual meaning of the award to you? What were your emotions around receiving it?
Do you know what? Just at the time and reflecting on the last couple of months, is probably the greatest honor of my life. And it was more so because of the emails and other contact that I received from people I hadn't talked about or seen for years, just emailing me, congratulating me, just reminiscing through our journey together. I feel super embarrassed about the award, to be honest, with an incredible colleague sitting to the next to me and Dr. Pope and many other people that I know that are probably more deserving of this award. It's hard to know how someone makes the decision for honoring someone with the Order of Canada. For me, to be quite honest, it's more a reflection of being in a small community and willing to do anything that they ask. And it was a combination of my role, I really think, during COVID and working with the provincial government in being the face of COVID and trying to explain the modeling and what may happen. It's also my work within the university in various leadership positions and building databases and structures to help the common good rather than a research focus per se. I think it's always nice when you excel or are able to hold your ground in something that you're interested in. But I think it was a whole bunch of things that came together, to be quite honest. It's not one thing that I do well, is the way I feel.
I think we have to set the record straight, though. It's about, I think, all of it, Proton. It's systems that you were involved in that integral in setting up or performing well, bringing up the team as you went, and various university and public health systems, research institute systems, and also a legacy of research, patient care, teaching, but in particular research, some of which was really groundbreaking. So never be embarrassed. We're thrilled and so happy and proud on our behalf to even be able to say you're a great colleague.
Anyway, thank you for saying that. It means a lot. Thank you.
Perhaps then we can go back to the beginning of your story and work our way forward. I'm curious what led you to medicine and rheumatology in particular.
My dad is in electrical engineering, and he was adamant that all his kids do engineering. My sister, who was 2 years older than me, followed that route. And so I was about to go into engineering. And at the time, he had this idea, and he was a very bright man, but was stuck in his ways as well, that maybe doing some courses before going into engineering would help you understand things a little better. So I enrolled my first year taking general courses towards engineering. And for the 3 years prior to that, I was just having worsening back stiffness, pain. Just thought I was really active in soccer, and I think I'm really good, but I'm not really. I just love to play and have a lot of passion towards the sport. So I thought it was just all the time that I was in the soccer field that I was having the trouble. And after sitting when the classes started in university, I just started having worse and worse issues with spondyloarthritis, and at that time wasn't diagnosed. It took about 2 years. And for a while, because I was being followed for orthopedics, they put me on a Boston Blue Jackets. I'm not sure if you know what that is, but it's one of these really...
Like a straitjacket.
A straitjacket, but
Makes
it was
you
very
stiffer.
firm. And with the understanding that they thought, because my bone scan lit up at the time, I had degenerative disc disease, and this is the way they were going to stabilize my spine because I had chronic issues. And that, I'm not quite sure how, led to a fair bit of neurological issues where I had some trouble with instability. So I spent about a year away from the university. I spent about a year and a half with a physiotherapist. So I felt like I'd be a bit behind my friends in going back to engineering. So I thought, maybe I'd do physiotherapy. And Dad just said, if you're thinking about health sciences, why don't you try for medicine? And that was a decision point. So I didn't think about it at all in high school and not at the start of my career.
And then after getting into medicine, why did you end up in rheumatology? Was it directly related to your medical history?
I think so, but I'm not sure if I would say directly related. So when I first started off in med school, I used to walk with a cane. So this is before pre-biologics. And it just so happens that the regular anti-inflammatories weren't working as well. I had an incredible rheumatologist, which was Dr. Hawkins, who had looked after me, but it got to the point, because he was very savvy about treating it, that, Janet, you remember this drug called phenylbutazone, and it's the indomethacin at really high doses wouldn't work, and that's the only option he had. A hematologist got panicked about it because he said, you're going to get aplastic anemia, you have to stop it. So it wasn't an easy course. And so when you haven't been to the OR, a surgical career is not top of mind. When you can't sit for a while, maybe radiology isn't the ideal thing for you. So I had to do something where I could take breaks in between. And so once I got exposed to rheumatology, that's how it came about. That being said, it's just the greatest decision ever, because a chance to relate to the patients is just the greatest gift in practicing medicine for me, because it's just, the patients come up and say, how are you doing, doc? In the sense that they know when I'm having a good day, when I'm having a bad day. And that bond, it's just, for me, it's been the greatest.
And what a gift, too, that the patients are aware and that you can have the empathy really based on personal lived experience. I think I have empathy, but you really don't know what someone else is going through. You can be empathetic, but you know what they're going through.
Yeah, absolutely, Janet. And you don't have to go through this to be empathetic, as you said, but just little subtle things that no one would really pick up. How did you emerge in that intersection, knowing that if you can't turn, you're actually just darting in?
We advise everyone in Newfoundland not to be driving in St. John's. Kidding.
So just the subtle things that just through, as Janet said, through lived experience, it's been great. But it's just more the patients feel like they can relate to you. And it's been a really good experience.
And you came at a time from the pre-biologic. So for the listeners, phenylbutazone, I think racehorses still get it, but aplastic anemia, severe cytopenias are part of it. And it was always stronger than the NSAIDs, but it was like, for people knowing history, it was more like a chlorambucil that would really give aplastic anemia, cytopenias, that really isn't used in rheumatology anymore. It was that kind of thing, but it did change the lives of some people with ankylosing spondylitis, but you had to be pretty careful, and it still was not probably changing the natural history. So basically your career has evolved as the treatment for your disease has really dramatically evolved over time as well.
Absolutely. And now I went for a run yesterday, and it was like 12, 13K. Like, I can do whatever I want. And I run in the summer, I run most weeks. I do something all the time. I feel fantastic. Like, I constitutionally feel well. I can do anything. Still a few limitations, but yeah. It's been game changing for sure.
I don't think I could walk 13K. And that's really great.
Yeah.
It's interesting because in medical school, at least when I was there, they were pretty explicit that sharing anything of yourself with the patient it's not advised, because the visit's not about you. The patient doesn't need to know you as a person. That's not really terribly central to figuring out their diagnosis. And I think the more that I move into my career, I see that there's certainly a certain sense to that. You don't want to make a visit with the patient about yourself, of course, but when they know a little bit about you or see you as a human, that seems to be important in building relationship. And I think in your situation, while you're saying, of course, like, you can treat these diseases, you don't have to have it to be able to treat it. It seems that for you, maybe it's bridged some of the space between a clinician and a patient that seems important to your patients.
Yeah, so I appreciate that viewpoint as well, and I can see where they're coming from in the sense of keeping the focus entirely on the patient. For my circumstance, it's visible to a certain extent what I get, especially when you're not walking with the proper gait, which I think I am now, but just even people that are a bit more observant would realize that I'm stooped forward a little bit, and I turn with my whole body. So they pick it up pretty quickly. And so it's hard to know how to deal with it exactly. It's not the first thing I tell someone, just in terms of what it is. It's just in a really small community, they all know. And
I think that helps adherence. They realize you're human, that you're going to be recommending things that maybe you have tried things for them, and they're not going to ask, well, did you try this? It's always about TMI, not too much information. And it is when people are prying more, because sometimes that's the case. I think that's where you say, I'm getting paid to see you, and so it's about you. I'll do a joke, but I go, so it's about you, because people do know, like for women, they know if they're pregnant. It's obvious sometimes. They've asked me probably when I was 50-something, are you pregnant? It's hell no. But thanks for asking. But in general, they realize you are human, and that you're recommending from a perspective of our book knowledge, but for us without certain diseases that we're treating, with a lived experience of other patients. And we're all going to get something at some point. We're not immune to disease.
And I really think, Daniel, it also comforts them. And this is just my perspective. And we're dealing with chronic diseases and cure. It's possible, but not often. I think we manage most diseases, but I think we can comfort everyone. And there's a sense of warmth and comfort when you are vulnerable yourself. And it's a connection that, for me anyway, has worked okay. And I don't think too many patients are taken back. Usually they're the ones that initiate it. But yeah, the fact that I have it, I guess they could say, why aren't you any better?
I think they think you're pretty much better. And,
I doubt they're gonna.
A superstar. Yep.
you've had, if I have this right, you did medical school in Memorial University, internal medicine at Memorial, rheumatology residency and fellowship at U of T, and then you followed that up with postgraduate training in genetic epidemiology at University of Toronto as well. How did you find your way within rheumatology? How did you find your way towards genetics and genetic epidemiology? Where did that interest arise from?
Through great mentorship, actually. The interest in rheumatology, other than being self-driven, was really from what I consider my primary mentor, which was Dr. David Hawkins. So he was a rheumatologist himself, and I remember applying to rheumatology programs, and he said, which ones do you want to go to? And it's coming from St. John's, it's just not sure if anyone would take me, just in terms of a program. At that time, he called every single program director. It's just the way he was, just trying to champion where to go. And so I ended up in Toronto because when I was an internal medicine resident, I did an elective there, and I just really liked the program there. And I was lucky enough to run into Dr. Gladman. That's where the interest came in terms of research. Prior to that, coming out of Memorial, I didn't do any research at all. I just loved internal medicine. I thought this is what I wanted to do. I wanted to be a really good clinician, and I liked the diagnostic part of medicine, and really didn't think beyond that, to be quite honest. But then saw individuals that could do both, and so Dr. Inman was there, and as was Dr. Murray Urowitz, and they were just great mentors and role models in terms of what to do. And so Dr. Gladman took me under her wing, saying, okay, how about doing research with me? And her PSA program, psoriatic arthritis program, was well established by then. And so that really helped. And at that time, I knew that I was going to come back home to St. John's. And the question is, what's the best thing to do there? And there were a lot of bright clinical epidemiologists, and sitting to the right of me is Dr. Popak, that I just want to do something slightly different than clinical epi. And so I thought about health services research versus this new field called genetic epidemiology. And I was probably the second graduate of the genetic epidemiology program. And it fit really well with what I was going to do, because Newfoundland is a founder population known for its burden of genetic diseases. And I thought it would be a really nice fit if I did genetic epidemiology. So that part was slightly strategic, and it worked out beautifully, to be honest. But prior to that, it was just all serendipity. My very first rotation was with Dr. Gladman, and we just haven't parted ways since, to be honest.
And another Order of Canada winner, too.
We seem to bump into a lot of that story of people finding themselves in her orbit and being taken under her wing.
I'm still in her orbit, to be quite honest. Maybe not as important as the fellows that she has now or the young faculty, but yeah, so she is an incredible mentor and still stays in touch with everyone.
This is almost a silly question, but I'm wondering if you can describe in a bit more detail the focus of your research over the course of your career. What really have you been working on? What are you trying to answer?
Trying to determine or elucidate the genetic determinants. So I think for any complex disease, the younger something starts, the more genetic it is. But even for diseases that we deal with in adults, there's a genetic component to this. There's likely an environmental component, and they come together with a particular trigger that initiates inflammatory arthritis. Just trying to understand the contribution that genetics plays to these diseases. Initially, I was naive and I thought we'd be able to identify a gene or a few genes. So the diseases went from monogenic to oligogenic to polygenic. Now it seems like there's just thousands of little variants that cause the entity. And so now we are not talking about genes per se, but something called a polygenic risk score. How can we take a bunch of genes together and determine risk based on it, whether it's for diagnosis or prognosis or related to therapeutic response. And that's the heart of this, is a belief that there is a genetic component to it. And I still think that's the case, just looking at the familial nature, just being in clinic, right? So when you have someone with psoriasis or psoriatic arthritis, it's not unusual at all to get another first-degree relative to be involved, to have one of these entities. And it's just, it can't be by chance. So there must be a reason for this.
You've said in an interview that there are very few eureka moments in the lab. I'm wondering if you could describe some that you have had.
I've made more mistakes, to be honest, and there are times when I really have thought I had something only for it not to be validated. So there's no greater joy in finding something in the lab for which someone else can validate. It's tricky work, and you certainly don't want to mislead anyone, but when you are testing initially thousands and now millions of markers, in the absence of functional studies, because we get to a point when we publish that functional part hasn't been done, it's a little tricky to be absolutely sure. So what I've actually built is humility. So what am I most proud of? Probably collaborations, to be quite honest, in any one thing that's come out of the lab, because what I have failed to do is have something that is clinically actionable, and that's my goal. Little improvements and little things that I'm proud of is, for instance, about 10, 15 years ago, they were going to take away B27 testing from the family physicians because they felt that our province was too expensive to do. And so we turned the serological test into a molecular test for $4, which our health authorities adopted and used since. So this is just a
It's a big
SIP
win.
association
Big win, though.
with B27 that stood the test of time. It's been just as accurate. And so there's certain things that have certainly happened, but I just am really careful, Daniel, not to take credit for things that I don't do. And so as a group, I think we've done a fair bit. But as an individual, I'm not quite sure what my contribution was.
Many.
So.
And I do remember when you were in your postdoc kind of training, so post-room, doing your master's. And I remember you gave this eloquent oral presentation that if I understood genetics, I would have understood it. But you did make it clear at the time. And then I think you were like New England Journal within weeks or something of that. It was amazing. And that's, again, it takes a village, but you're part of the team player and a team leader. It's amazing.
That answers. Someone had warned me that you're so humble that if we ask you to describe your contributions, you might struggle to do that, not because you have none, but because you routinely do not take credit, or you share the credit so broadly that you take yourself out of it. But I really appreciate your answer. I think when I have watched House on TV, the whole point of that show is his genius comes at a cost and his diagnostic skills come at a cost. He's a mean guy, but that's just what genius looks like. And I think in talking to you and also your colleagues, I think you're a really good example that you can be a decent human being and also brilliant. So I do appreciate you trying your best to answer these questions.
It's a funny anecdote, actually, because I'm not sure what my wife is watching now. She's trying to get me to, is it The Pitch? I just don't know which medical show is it all. But the residents, what's the name they used to call me was, I think, House. I'm not sure what the actual name was for, because I don't actually watch the shows too often, but that's what they used to refer me to as. So I just love
For the genius,
problems.
For the genius.
No.
House always made the diagnosis, not for the meanness.
I think that both of you are the same. Just being in rheumatology, you like complex issues, you like sorting through things, and still love the general medicine part of sorting out problems.
I'm curious what some of the burning questions you feel you still need to answer in your career.
What I'd really like to see, and so I guess I answer it in a slightly different way, was my very first point in the basic science presentation at this particular meeting, and that's I really think we actually have a lot of therapies, and I think we actually have a lot of genes. I don't think what we do is test very well. What I'd like to do is work with people like Janet and others that are in health technology assessments and put a value to what we actually have that we can potentially test to see what the utility is. And then either go to the funders or the companies and say, the issue is with trying to push the precision medicine initiative forward is that we're not testing enough. All our resources go into more and more drug development. We actually have a lot of companion diagnostics with various agents that we can actually make more efficient. We actually have a lot of variants that we think are just monogenic that may be playing a part in complex diseases. If we test more, we can get an idea of which are the targets. The pediatricians do it really well with their autoinflammatory disease, for which there's more four pathways you try to identify to tailor your therapy towards. I think that's where we should go, right? And so that's my passion is, okay, so people are actually coming up with all sorts of stuff, and then we're just dropping them. Let's take them forward and see what the utility of what we have is. You can always discover more, but we've actually have a lot to work with right now.
I think it would go as well. We heard the talk today out of the Toronto group that in psoriatic arthritis, the SNPs and various gene variants are different between men and women. So it's not just an X or a estrogen thing or a hormonal thing. It's really, there are variants and that will change manifestations. But I think it's even more, would we get like the right drug order? Because the average delta of response is the same in each, we'll say advanced therapy and PSA in general, a little bit different on skin than on our PSA, but the delta is about the same. And then this patient goes through this pathway, another one, we have something in the fridge or the cupboard, so they go through a different group. But it's also the dosing. When the drug turns off the benefit, is it antibodies? Is it upregulation of genes, transport genes or something? Or is it the wrong dose to begin with and we should be updosing? And I think our IBD colleagues have it way better, even though, of course, this is in its infancy to make a test that is a good companion that really tells me which drug, which dose, and whether a man, woman, early disease, late disease, what all you failed would make a difference. But I think others are getting ahead of us in that way. And that would be a rational utilization of drugs, rational dosing, and a rational order. Because right now, all guidelines are just do stuff. If they're not better, do more stuff and change it. If they're not better, maybe add or cycle back or whatever, keep going. And I don't think that's very helpful. And I don't think they would do that in chemotherapy anymore. Maybe back in the day, but not now in so many diseases. So I think we can learn from oncology, GI, from, as you say, pediatrics, PD room, etc. So we will get there in your lifetime, but it'll take bits and pieces at a time.
Yeah, absolutely agree. Yeah.
So is that sort of, I was curious about where you saw the specialty in 10, 15 years, and it seems you're steering towards an answer of the real paradigm shift is more in precision and personalized medicine rather than that we come up with a cure antibody. That's not really how the disease works. The disease has so many different aspects to it, multiple genetic kind of components that are all factors, but no single target. Is it the precision that you see becoming more the focus of research?
Yeah, I think so. The diseases are always going to be heterogeneous. They're always going to be overlapping. Where do I see things? Probably more towards an oncology-like infrastructure in terms of how much time they spend testing tissues, testing blood, and they do it with fair amount of speed. Right now, we send for genetic testing. We wait so long to get the results. We made our decision prior to it because we just can't seem to wait. But they don't wait as long for what to get back, and often hitting with multiple targets at once to try to calm things down. And once you let the horse out of the barn, it's really hard to put it back in. Really conceptually like the idea of hitting with multiple targets early, trying to quieten things down, and then maintaining with the lowest amount possible.
And retesting when things go askew.
Yeah.
We don't even know when, I'll call it something that might be easy enough where we might have been able to do or could do a synovial biopsy, because it's not the fluid, right? It might be the cells. To look at that level, when GI will say, why'd you change the drug on the patient? It's, I don't know, it stopped working, but I don't really know why I changed it or why I changed it to whatever it was available. And that is really in the 21st century, it will change. And there will be lots of companies supporting, I think, using the drugs we have effectively and cost effectively if we actually know what we should be doing, at least with a higher index of suspicion, a higher odds ratio or hazard ratio.
And I need to be careful in how this is interpreted. But I always question as well some of our outcome measures and how we're assessing things. And I think a molecular approach may actually be superior in the sense that we can do single cell sequencing and a fair bit of intricacy in terms of getting an idea of what's active and what's not. And yet, for instance, we're using a balloon to measure blood pressure. And because it's worked as a surrogate for something, we've kept on doing it. And it would be a huge kind of paradigm shift to get away from that. But there are probably other ways we can actually come up with an endotype that'll actually give us a more accurate answer to who's about to get an infarct or who's about
It'll be their watch, the change in beat-to-beat variability, right, before they have
yeah.
their heart attack. But I think you're totally right. And again, I know what you're thinking as a lived experience, but also with all your experience with patients, that the patient's voice absolutely matters. How people feel matters. And we do try to treat to make them feel better. But then trying to intertwine how you feel as being more active disease or less active disease when you feel better, and you might then flare in 2 days, is a little bit, I think, archaic, a little bit, and that we can go further and say, I am going to predict a flare. Wouldn't that be great to know with a very high amount of accuracy? So please get back on being a bit more adherent. Get back on your bandwagon of taking your drugs. We're not there yet.
The other thing I've noticed, Daniel, is, and maybe this is just me, is it's getting tougher and tougher to be a general rheumatologist. There's just so many things going on that I'm getting more insecure. There was a time when I felt good about rheum, but maybe not so much about medicine because I wasn't doing it all the time. Now, occasionally, I feel like I'm missing out on something that I should know about. I just need to reach out. And in bigger centers, you have the expertise where you can funnel different types of patients. So that angst maybe not there as much. But for me now, it's just, and maybe it's age, I'm not sure. But yeah, there's increasing insecurity. Proton, have you missed something?
It's all the mysterious cases that were already presented this week at the CRA. I thought fail. One of them I had even heard of, and I might have even been on a podcast before. I still failed on that case. It's like, I don't know. But I think the bottom line is we need help. We need lifelines from others. The hardest part in medicine, I think, is knowing where you're out of your lane. With experience, we get that better, but to just really say, I don't know that. And I know there's some things I'll never know. And that's okay. It's like there's a pattern recognition that I don't know what this is, but I know somebody over here might. And that's the beauty of not just sending the patient physically out of the province to be seeing someone else, but asking, emailing, talking, taking some pictures, getting the other specialists involved.
And the greatest value of, so for instance, being a distinguished investigator, which I think Janet and I both are, I don't feel stupid about asking anymore. If I just don't know, I just ask. I've gone beyond that stage where someone's going to say,
yeah, we know our limits. Finally, it's good to know.
I think that's almost the soft curriculum of rheumatology, though, is because we don't own a single organ. And we see a broad spectrum of diseases. We get called into unanswered cases with some frequency. I think that's your humility, both of you. That is part of being good at the work, as I see it, is there are certain patterns you will recognize. And as soon as it's beyond that pattern, asking for help or wondering if you have the wrong diagnosis or you're the wrong doctor to see them, the wrong specialty, I think that sort of is part of the job. So I see that as more of a master clinician level when you start to turn back in and say, oh, I don't know what that is. Am I seeing a disease that we just didn't know about before? When we do the mysterious cases, that reminds me that just because we have this many diseases described, there's no reason why that's all the diseases there are. Like there's no reason to believe we have finished categorizing all diseases. Of course we haven't. And even though we may have similar phenotypes, your genetic research shows like there's a lot contributing to that phenotype. There's a lot of heterogeneity even within back pain. There's a lot going on there. It's not so simple. So
this really rings true for me, and it's something that I struggle with and trying to teach my colleagues at home. And so we do genetic testing when we can avail of it. And lots of times we are identifying pathogenic variants. You got a sense that there's something here that's not right. Either it's young or familial or just into one of these classic autoinflammatory patterns that is not specified or and so undifferentiated at the present time. But then you come across a pathogenic variant that sort of fits, but it's heterozygous rather than homozygous. And our geneticists is really well intended because they're the ones, it's their budget, they pay for it, they give us the assessment saying it's a variant of unknown significance, no clinical action needed. I don't agree. I just don't. I said, what's the probability that they have something and it just happens to be heterozygous, but it fits into this particular mold, and lots of times kind of respectfully acknowledged their opinion, but at the same time moved on, treated it accordingly. And so TRAPS would be a really good example, and the patients have improved. And so I think there's so much heterogeneity that's actually involved. And it's a bit of an art, as you said. And medicine is really, it's a probabilistic science rather than deterministic. And so to me, so what's the probability that this looks autoinflammatory and there's an autoinflammatory gene that's pathogenic but missing a variant? I think it's related. And let's go that way.
Absolutely. And we hate those uncertain significance, but usually it comes back 8 months later anyway to test. So you've already moved on and treated, as you say. I think the other thing is kids in particular, the complexity of their genotype leading to phenotype. I am so surprised how many of the JIA kids change lanes, where a posse becomes a lupus patient, SLE, when she's 22 years old. Or an oligo that looks like a JIA HLA-B27 type, then gets something and you go, well, I didn't think that this disease was, they get an ANCA, vasculitis, and not P-ANCA where it's a false positive. It's so I think the plasticity of the immune system and the orchestra of these variants is really something that maybe AI will help us with down the road, but we just can't predict. And you could have someone, even HLA-B27 positive patients in the Caucasian population, only about 1 in 8 will have ankylosing spondylitis. Some might have other axial SPA, uveitis things, but not everyone will manifest DR4, double hit, 0101. Many of them won't get RA. It's about 20% of DR4s in certain populations, and RA at most 2%, mostly 1%. So I think what you've done in your research humbles all of us to realize that what we know, and there's so much more that we don't know, and it will continue.
And I just only wish that we could take some of it and just try, maybe not act on it clinically, but unless we test it in a clinical scenario, we're never really getting the full benefit of what we've actually done in the lab. It's just, there's a last mile problem, and the last mile is no one wants to take something that's not working and implement it, but it's actually not tested properly to know what the impact is and what the value would be. And then there's the issue of cost and paying for it. But if those are aligned, then I think a lot more things can potentially be of benefit. And a lot of what drives medicine, from the way I see it, is the potential financial gain. And just when it comes to precision medicine, I think market segmentation is not pro-pharma, right? Because what they like to do is to have a pool of population for which they can try it on everyone and then see who works the best, and they'll stay on it. And this is something that we actually would have to try to identify, is which is the subset of a particular disease that best fits this drug.
Before we close our discussion, I was hoping to hear if you have any sort of major reflections from your career. You've been a clinician, a scientist, a learner. You've worn many hats. And I'm curious if you have any 10,000-foot view reflections to share with us.
I think the most important thing to do, and is something that probably Janet has done the best of anyone that I can actually think of, is to teach. If you have a skill, just share it. And I've tried to do it, but there's only so much that I know. But there are people like Dr. Pope and Dr. Gladman and others that just naturally have done it. And at the end of the day, it's just to help just the whole population, help our patients in whatever, keep them healthy. And there's just too much going on that if you can share your knowledge and do it in a respectful way, it'll help everyone along.
Wonderful.
Thank you so much for coming on the podcast. It was so nice to get a chance to chat with you.
Great. Thanks for having me. Thank you.
That was Dr. Proton Rahman, a giant in the field of rheumatology, a pillar of the Canadian rheumatology community, an East Coast rheumatology hero, and now a member of the Order of Canada. That's it for this episode of Around the Room, recorded here in Halifax at the CRA Annual Scientific Meeting. Around the Room is produced by David McGuffin, Dr. Dax Ramsey, and Aaron Stewart. We would like to give a special thanks to the Communications Committee and the staff of the CRA for their hard work. Our theme music was composed by Aaron Fontwell. If you enjoyed your time with us, please give us a rating and review where you listen. It helps us to build our community. And please subscribe so you don't miss future episodes. With Janet Pope, I'm Daniel Ennis. Thanks so much for listening.